Hey, and welcome to this version of Webinars on Demand. We're going to carry on with the theme we started last time, that is shoulder pain. But this time, instead of looking at point pain, we'll be looking at more generalized pain, specifically in the left shoulder. Um, so, last week we talked about point pain and we concentrated on labral tears, tendinopathies, particularly tendinosis, and AC joint problems. And we looked at the etiologies and the diagnosis of each. So this time we will look more at generalized pain, and this is crap. So we're going to start again. Two, go. Hi, welcome to this week's webinar. We're going to be looking at shoulder pain again as we did last week, but this time we'll be looking at generalized shoulder pain. And we'll see if we can link something between the two. But first, to the quiz. And what we have is two very ex-presidents. So the question is, apart from both of them being assassinated, what else do they have in common? And it's obviously in their facial features. So I'm going to give you a few seconds to look at this. Not too long, just enough time as if you're looking at a patient. Let's see how you do with it. So we're moving on. And we're going to start the presentation on big chunks of categorization. Cardiac, visceral, shoulder pain itself, and also referred from the neck. So if we look at the left lateral arm, we can include cardiac with this, as that's generally speaking where heart pain will be felt. It will be felt as an ache on the outside of the arm, this way, and often the patient will just consider it a minor irritation and may well walk around with it for days, rubbing it. The pain isn't related to shoulder movement. If anything, it's going to be related to emotional stress and general body activity. In fact, the pain is unaffected by shoulder movement, or in fact, shoulder movement may help relieve it a little bit, provided it's not too exertive. The shoulder on examination will have full range of motion and will not reproduce pain, or if not full range, near full range. But this one's not difficult. The patient generally doesn't look well. They may be dyspneic, sweating, just feeling icky. This really shouldn't come into your clinic as an undiagnosed shoulder problem, but it's very possible that a patient that you're treating may start to exhibit these symptoms, and it's just as well you recognise them for what they are. Visceral pain. There are two types of pain from the viscera, one from the organ itself and the other one from the lining of the organ. So the major neurological differences between the two is that the organ is innervated fairly sparsely by nociceptors, and the subserving nerves tend to be small and unmyelinated. And because of this, you get very characteristic pain with this. It's a deep, dull ache of a pain that tends to come in waves. The lining, on the other hand, are well innervated by nociceptors and myelinated nerves. So this takes on a normal musculoskeletal quality to it. This one can be quite difficult. I've seen two cases of pleural pain, and I've misdiagnosed both of them. And the problem with the pleural is, so now that whenever the patient turned, either in function or in activity, this pulled on the pleura was painful, and that's what they felt. At the same time, they also had biomechanical dysfunctions, which is not uncommon for people who have asymptomatic biomechanical dysfunctions in the same area. Anyway, manipulated those and made no difference to pain after a couple or three treatments. So I decided that was enough. Sent them back to the doctor, and it turned out that one of them had pleural effusion and the other one had pleural adhesions. I'll probably mess the next one up as well. I really don't know how I could have diagnosed that differently, other than maybe osculating them, which on hindsight I should have done, but instead of that I sent the doctor up. The organic pain, though, is a different animal, and it's very, very characteristic pain. It's that heavy, deep, diffuse pain. And in the shoulder it tends to come over onto the, there's my left, onto we're doing the left side. So this is coming over the top of the trapezius and then down into the arm itself. So it sort of radiates this way, and it just feels like a pressure and just keeps pushing down and pushing down and pushing down. And it's actually quite intolerable eventually. Um, it does come in waves often, and the organ at fault now is organs that can actually irritate the dura. Sorry, not the dura, the diaphragm. So that this now is being innervated around the periphery from the neck, and so it refers upwards into the shoulder area. It's unaffected by shoulder movements. Again, that may ease it somewhat, and again, the patient feels better with general activity. Shoulder has full range of motion, and the patient may or may not be unwell. It's not a steady thing, that. So let's get on to the areas that we do look at. And we'll move up from the little pink square up into spondylogenic pain, referred from the neck. Now, referred pain from anything tends to be an ache, not sharp stabbing pains, but an ache. And as soon as somebody talks to you about shooting pain, stabbing pains going along a limb, the first thing that comes to mind is it neuropathic? But we've talked about that. Neuropathic pain will have definite characteristics that you can ask about. But referred pain tends to ache. The other thing about referred pain is that it is directly related in intensity to the source. So the more painful the neck is, the more likely you are to have referred pain, and the more painful the neck is, the worse the referred pain will get. It also tends not to come on when you're just moving. So when you test the neck, or any other joint for that matter, it's unlikely that those tests will be painful distally. You'll reproduce the neck pain, but it's unlikely that the distal pain will come on. This comes on over time. So prolonged positions with the neck, working your head a lot, where you're looking around a lot of examination, the patient will tell you, well, I weren't too bad when I went home, but that night I had pain all down the arm. So it tends to be a prolonged stress that brings on the referred pain, not just an individual movement. And of course, the shoulder range of motion will be pain-free. Pain from the shoulder can be sharp and achy. Remembering that this pain coming down here is referred. This isn't local pain. This is referred pain. So if you think about this extending down into the forearm and sometimes even to the hand, it's rare, but it can, then it's obvious that this is referred pain, but so is this. So this tends to be an ache. The tissue that's causing the pain, on the other hand, tends to be a point tissue, unless it's a joint, and then the whole shoulder joint will have an acute painful, so you'll just feel it in that area very acutely, and then it will also refer down the arm. So it tends to be an ache. It can be a very intense ache, but it tends to be an ache. It's obviously related to shoulder movement, and when you examine the shoulder, you're going to find restrictions of the shoulder and pain on movement. There isn't that same relationship that you had in the neck, where when the shoulder's bad, the arm's pain. It's difficult to separate the shoulder pain from that referred pain, except in the intensity. So if you're moving the shoulder around, you'll get a sudden sharp stab of pain around the shoulder, then followed by the aching, but it's difficult to talk about intensity. The problem with this type of pain is that this pain that comes down the arm this way tends to be caused by arthropathies of one kind or another. Not totally, that's not completely true, but most of the time it's due to an arthropathy. The real problem starts is when you have referred pain from the neck and local pain from the shoulder, because the referral area for both is the same. Now, one giveaway is that with referred pain from the neck, there's usually a topological connection. So the shoulder pain will be felt here, but also up into the trapezius and into the neck. It's going to be unusual for you to find an isolated referred pain that isn't also painful in the neck and isn't linked to the neck in area. So this is one giveaway. But when you've got both of them going, you're getting everything going on. And when you examine this, it sounds like they are both at fault. And in fact, they are both at fault, but they're behaving differently. This pain may come on with neck postures, or it may come on with shoulder movement. and obviously moving both the neck and the shoulder in this case, you'll reproduce these pains and you'll find limitations of movement. So this stuff takes a little bit more thought, but it's not that difficult. Now, let's get a bit more specific. So if we look at the purpley rectangle in the middle as a starting point, and if we go to the right, in this case, going that way across the screen, that's to the right of the screen, then we come back to what we was talking about last time, point pain. So this is just a recap of what we did last time, but it's worth mentioning that something like a tendonitis will or can, because it's so painful, spread the pain all over the shoulder. So this is one instance where pain going down the arm and from the shoulder isn't due to the joint. It's just due to the intensity and the amount of lateral recruitment that's occurring. And it may not be in a dermatomal pattern, it may radiate, so it just spreads around this way, just because of the intensity of the thing. Now, going the other way now, which is what we really want to talk about, and we're going to generalise pain. Now, if you come back on this, on the above and below the purple square, we have two referred pain, the visceral and the cervical. We spoke about these to some extent in the previous slide. So if it's okay with you, I will move on and we'll go over to the left of the blue rectangle. So we're dealing with capsulopathies, arthritis and fractures, which also has got to include traumatic arthritis, obviously. So let's have a look at capsulopathy. Well, actually, before I start this, when we're talking about an arthritis, we're talking about the joint being inflamed, but this can also be an arthrosis. Where I've got arthritis out there, I've included OA in that. Cyriax gave the capsular pattern of the shoulder as limited lateral rotation, less limitation of abduction, and least limitation of medial rotation. Now, this was based on you testing medial rotation with the arm by the side and not trying to put the arm up the back, because if you do it that way, medial rotation is typically the most limited movement. In fact, it's the one movement that the patients do complain about. They can't put their hand in their back pocket, they can't do their bra up, and at the same time they may mention they can't reach overhead. But medial rotation becomes their real problem here. That is not medial rotation. That's medial rotation, extension, protraction of the whole shoulder girdle. There's an awful adduction. There's an awful lot of stuff going on there. So don't test it by putting the arm up the back unless you're just using it as a screen. So the other problem with the capsular pattern as described by Cyriax is he never bothered with the other movements, flexion, extension, ab and adduction rather. And if you stabilise the scapula when you're doing all these movements, then you start seeing that these other movements are limited as well. But for the most part, Cyriax's description of this isn't too bad. Now, if we have a fibrosis rather than an arthrosis, which is how a capsulopathy ends up, with the whole shoulder capsules tight like that, then you have a different limitation. Everything is limited, and everything is limited badly. So we're talking about arthritis and arthrosis when we talk about a capsular pattern. So, bearing that in mind, we'll go to the capsulopathy, or frozen shoulder, or adhesive capsulitis, or whatever you want to call it. This is not a joint affliction, it's a joint capsule that's in trouble now. Mostly it affects middle-aged women. All of the range of motions are limited with some pain if you take it far away. There's no range of motion that is free. Even medial rotation is painful when you get there. And it tends to come in three stages. A worsening phase, a leveling phase where it plateaus, and then an improving stage, or in the vernacular, freezing, frozen and thawing. And they tend to be equal amounts between each stage if the shoulder's not treated. So you have 3 or 6 months of it getting worse, 3 or 6 months of it staying about the same, or 3 or 6 months of it improving. So overall it's anywhere between 9 and 18 months typically. The chances are if it's not following that pattern, it probably isn't a capsulopathy. The MRI actually can help with this, differentiate this out. So obviously can blood tests, and probably all of this should be done before you start getting at them. Often before the onset of this, there is a period of restricted movement and pain, but often not. Often not. Okay, now arthritis, arthrosis. Um, if we look at this, we can think of this in terms of systemic arthropathy, degenerative arthropathy, and maybe diabetic arthropathy, although probably diabetic could be put in a systemic arthropathy, but it's not normally thought of in that way. So things like rheumatoid arthritis, ankylosing spondylitis, that type of thing tend to affect this joint. And the chance of you seeing the first episode is not very high, so they will probably have a history of flare-ups and subsidence. It sort of get bad and get worse, and the chances are of an undiagnosed rheumatoid shoulder coming into your clinic is not very high at all. But it is something to keep in mind. It's very painful when these flare-ups occur. They're very painful. The range of movement just drops way down and is irritable. A little movement can create a lot of pain for a very short time. So a little trigger, big consequence. Often there's other joints involved. Enthesitis are not uncommon. In fact, often other joints are involved. So again, this is not something that you really should be missing and thinking it's something that it's an adhesive capsulitis, for example. You won't get that episodic history from a capsulitis. Degenerative arthritis, osteoarthritis, or osteoarthrosis. Arthrosis may not be painful. It needs some inflammation to make it painful, or arthrosis, particularly if you've got a lot of ebonation occurring, can be painful all by itself. But this pain tends to be less severe than the systemic arthritis is. So you still get this episodic. Pain's on and off. It may go away completely and then come back again. It isn't as severe as the previous one. Then, if it's bad enough, there may be crepitus. You will find restriction of movement, and the restriction can really be quite bad. And often, well, not often, but sometimes, the arthritis will become a fibrosis, and you get a lot of restriction of range there. X-ray is probably the easiest test to find out if it is this or not, but it's fairly standalone diagnosis. There isn't much that mimics this. And then diabetic arthropathies. Very difficult to tell apart from capsulopathies and arthritis. They can be very severe or not too bad. It depends on how bad the degeneration is occurring, because that's what this is. The sugar will damage a nerve. You have a neuropathy. And you can also get inflammation from sugar. So just by itself, the sugar itself can cause a sugar arthritis. But that nociception loss, because of the neuropathy, leads to basically Charcot joints. So you get a lot of degeneration occurring very quickly unless this is put under control. As I say, it's difficult to tell apart, but this obviously isn't a simple thing. And your biggest problem is going to be telling the capsulopathy from the diabetic arthropathy, simply because neither of them may have previous episodes, and they both start off similar. And until that capsulopathy goes through two of the stages at least, where you can identify distinct stages, the chances are you won't be able to tell the difference. So my feeling is that blood tests are not a bad idea before you start treating an adhesive capsulitis. So hopefully, if it's been referred by a physician, it has been tested. If not, then maybe you should talk to the physician about it. Or if you've seen them walk straight in off the door. And of course, with diabetes, simple blood tests should give you that information. Moving on down, we have fractures. Now, this is not difficult. These are often middle-aged or elderly women. They've fallen. It's a trauma, sudden onset of severe pain. At least the pain is as severe as it gets for this person for that problem. Regardless of how much pain they get, they lose function. And it's the same with the dislocation. I haven't brought this in there, but it's exactly the same with the dislocation. A complete dislocation, you've lost all function, severe pain, and you can see the deformity. Partial dislocations are a bit more difficult to deal with, but again, it's a sudden onset of functional loss of movement, and so it comes out of it. Both of these cases will have an arthritis associated with it, but it is dominated by the picture of tissue damage, healthy tissue damage. Now, if we look at point pain, you'll see that there's coming off the bottom of it an arrow going to bursitis. Now, bursitis and point pain depends on, as I say, actually the amount of pain you get from bursitis depends on which bursa is affected and how badly inflamed it is. You can sometimes get bursitis, and you see this in the elbow, where a patient will come in with a golf ball sticking out of their elbow, basically, and you've got an olecranon bursitis there, and it isn't painful. It's not even tender. You get them push on it, and basically, if they do surgery, it's for cosmetic reasons more than anything else. So you can have a very swollen bursa that simply isn't painful. I have no idea why, but that's the way it goes. The same thing in the shoulder. I've seen patients with a cutaneous bursitis that looks like an egg sitting right on top of their shoulder, and it's not been painful. Again, you can press on it. At the same time, some people, there can be almost no swelling, and bang, they can't move it. In England, we used to see a lot of patients that were diagnosed as subdeltoid bursitis, acute subdeltoid bursitis. I've never seen one in North America. I don't know if it's a misdiagnosis over there, but otherwise I've never seen this syndrome neither. And this is, generally speaking, it's a middle-aged woman, and they'll go from having a perfectly normal shoulder and in the space of hours lose all function in it. They can't move their arm away from their side because of the amount of pain they're getting. With their arm by their side, they can medially and rotate it, okay, but any movement to take it away from the side, and it doesn't, it just hurts too much when they do it. If you examine this, this is one of the few cases where you can find an empty end fill that isn't serious. Nothing stops you moving it. The patient's trying to let you move it, you're lifting it up and it's going, and the patient's sitting there, starts sweating, then starts screaming, and then people start leaving the waiting room. And you stop the test. The patient doesn't. They avoid guarding it, they do everything they can to let you do the test, but they can't do it. And this is an empty end fill. So, as I say, I've never seen this in North America, ever. So bursitis are capable. This one does hurt. It hurts all around the shoulder. It goes a good way down the arm. This is one of the most painful conditions I know of. Your best bet to treat this basically is to immobilise the arm. Use stim to get the pain down, but otherwise don't try and move it. This won't turn into a frozen shoulder, and you'll just aggravate the hell out of the thing and keep it going longer than it needs to be. Now, if you treat this, it'll get better in about 10 days, and if you don't treat it, it'll get better in about a week and a half. You can, though, with your treatment, by making them rest it, actually lessen their agony for a big part of that recovery time. So that in itself is worth doing. But don't move them about and jiggle it. Okay, so that's a very quick look around shoulder pain. Last week, point pain. This week, general pain. Okay, so we're going to look at the quiz now, and I just want to show you this. Adele, yeah, upside down. She's in Australia performing a concert, and there she is upside down. Now, let's turn her the right way up, and that's her now. And the fact is that you had no, unless you've seen this photograph before, you have no idea that this is happening. I'll flip it back, and I swear to God, this is exactly the same picture. Just one up and one down. And your perceptual system just cuts this out. It says, nope, not having any of that. And by putting them upside down, you give them an opportunity to really work well. But even when you know it's there, you still can't see it. Now, the point of this is that. If you look at faces casually, you can miss stuff, and we all do it. As you're going to tell me, it's not your job to pick out these neurological conditions, and it's not your job. But if they're in your clinic and it hasn't been recognised, you really should try to understand that you need to recognise it. So if you stop looking at faces casually and a little bit more critically, you might see a little bit more. Now, this isn't an uncommon thing. This is strabismus. Probably from childhood, I honestly don't know, but probably from childhood, but it can also occur as a neurological pathology. Now in both cases, it's the left eye. John Kennedy's left eye is turning outwards, while Lincoln's left eye is looking upwards. Now, if this occurred in childhood and it's not fixed, then it tends to be a blind spot where it conflicts with the other eye muscles. Instead of getting diplopia, you just blank out that particular area to prevent diplopia. And you get atrophy in the brain and everything else. And that's what happens with this. And if you trace out their visual field, you'll often find that with these people. Anyway, there it is. You don't have to spend hours and loads in it, but what you need to do is know a normal face. So when something is abnormal, you can see it. Not easy. Okay, that's it for me. This screen is going to die in about 2 seconds, and I really don't know why, so I'll keep on chatting for a second. And hopefully you got something from this, and I'm not just telling you stuff you already know. If I am, let me know. If I need to make this more advanced, I will do it. I'm trying to mix advanced and more basic stuff in because I don't know the audience. But seriously, if you're not sure about the content, you don't like the content, you want it more advanced, less advanced, let me know. Okay, otherwise I will see you next time. Thank you for watching and take care, everybody. Bye.